Okay, great. Thank you. So welcome everyone, and welcome to folks who are still arriving. I'm honored and thrilled to be introducing Dr. Missler today, who's going to be talking to us. She met with Dr. Benetti and Dr. Santo Pietro and I last year when Bright Initiative was starting, and we were so impressed with her knowledge that we on the spot just knew we had to invite her back, and so we're really excited to have her here today. Dr. Missler is an associate professor of psychiatry and an attending psychiatrist at New Hampshire Hospital under a contract between Dartmouth-Hitchcock Health and the state of New Hampshire. She's a graduate of the University of Vermont Medical School and completed a residency in adult psychiatry at Dartmouth-Hitchcock Medical Center. While her interests in shared medical decision-making, mindful meditation, motivational interviewing, and violence in healthcare may sound disparate, the underlying theme of her work is that of reducing the power differential between patients and providers to foster engagement and alliance. And so this maps really well with system initiatives and things that are important to all of us. And so I'm, again, really thrilled. And just one housekeeping issue, I'll be monitoring the chat, and we'll be helping to be the go-between for any questions. And Dr. Missler has mentioned that she'll welcome questions during the presentation. Just throw them in the chat and I will bring them to her. So without any further interruption, Dr. Missler.
Thank you so much. I really appreciate the kind introduction. And I appreciate the opportunity to talk about a subject that I've been studying for several years now with great enthusiasm. So I'm really looking forward to this. So let me share the screen. Let's do slideshow. Right, of course. Nope. I'm not getting slideshow, am I? Try again. Are you getting slideshow? Maybe I'm looking at the wrong thing.
There was a really small resume slideshow button that popped up on the screen after you had pressed that.
Oh, I probably didn't see it. That was dumb. Okay, thanks. There's great. All right, there we go. That's the one. Perfect. All right, thank you. All right, so from what I understand, I'll be talking about healthcare workplace violence in general, but there's a specific situation in New Hampshire that we've been working with that I wanted to present to you as kind of an example of what could be done at kind of the grassroots level to start addressing this as an issue. What would click this forward? Ah, here we go. So I was told that I needed to put this on one of my two required slides. Do I need to leave it up for about how long?
We can revisit it later as well.
Okay, sorry. I was like, we have the same sort of thing. There's some sort of special code that we're supposed to have. So, and then of course I have nothing financial to declare or disclose, but nothing that I can speak about publicly, of course. So why don't we get started? I really hate when people, I think it's rude to read slides, but I am going to read this slide. So I apologize for being rude, but I think it's so important to hear. You know, workplace safety is inextricably linked to patient safety. Unless caregivers are given the protection, respect, and support they need, they're more likely to make errors, fail to follow safe practices, and not work well in teams. This statement actually makes an attempt to capture how I feel about workplace safety and violence. I think this is so key and one of the reasons that I'm so passionate about this. And before I begin, I want to sketch out some of the broader concepts I'll be covering in order to be as clear as possible. I do tend to talk fast, so also, let me know if I need to slow down as well. And feel free at any point to interrupt or pose a question in the chat forum, and I'll do my best to answer. I appreciate that Kevin's willing to monitor the chat forum because it is hard to multitask like that sometimes. So broad concepts. So first, I'm going to be focusing on healthcare workplace violence in general, okay? But will of necessity use varying sources of Yes, thank you. To illustrate my points, because there are no consistent comparable sources of data. There's no sort of centralized data or common forms or even common definitions of violence that people use. My interest in this topic is so far reaching, and I believe that in order to address it properly, we really need to address it on multiple levels. And so that'll be another key concept during this talk. And then finally, I just wanted to point out there are several types of workplace violence, and I believe the NIOSH and a couple of other places have called them different types of violence. So type 1 violence in a workplace is called criminal violence. So it's somebody who comes in that has no other relationship to the workplace and is trying to engage in some criminal act like robbery. Type 2 is customer to staff, and that would be like a patient to a staff member. Type 3, also called horizontal violence, is employee to employee. And type 4 violence in the workplace is where there's a personal relationship, often referred to as domestic violence, but usually when there's somebody, a family member who comes in and commits violence against somebody who's in the healthcare workplace. Type 2, the patient or customer to staff violence, is by far and away the most common in healthcare. So that's the one I'm going to focus on the most. But as you'll see from our pilot survey that we did in New Hampshire, and also from some emerging data across the country, type 3 or horizontal violence is quite common, but it's far less studied. I know a lot of folks talk about like nursing bullying, that sort of thing. So those are issues yet to be explored. So any questions before we start? It's how I usually feel every Monday, by the way. Nothing so far? Nothing in the chat? Okay. So here's the outline of what I'll be covering today. I'm going to start by giving you kind of the lay of the land by describing details of this major public health problem that is, according to the New England Journal of Medicine, largely tolerated and ignored. And I'll demonstrate how this has been ignored, even in New Hampshire. It may well be ignored in Connecticut. I would guess it might be at times. Then I'll introduce you to one of the reasons we still do not have any good solutions to the problem of healthcare workplace violence. In other realms of medicine, you may have heard of the research practice gap, in which we know what works. We have evidence for what works in a particular problem, but there's a large gap between when we have the evidence supporting what works and when it is implemented, oftentimes up to 17 years of a gap. Well, this is a different kind of research practice gap in which we have very little evidence to support what works to reduce violence, but we're still left with kind of figuring out how to address the problem in real time. We can't just wait till the evidence mounts, while we also try to investigate what works. And this is what led to our conducting a pilot survey here in New Hampshire, because we really wanted to understand the problem at the basic level. Then I'll show you some of the data from the pilot survey done by a group of which I'm a member, what's called the New Hampshire Violence Prevention Work Group. And this was in response to a request for data from the New Hampshire legislature. Based on the results from the pilot survey, the New Hampshire Violence Prevention Work Group has made several recommendations for future action to follow up, and I'll talk about those as well. But let's start with the scope of the problem. So we can see here very easily, workplace violence in general is a major public health problem. I mean, you can see that the green line, healthcare and social assistance, violent injuries resulting in days away from work, way, way, way higher than any of the others: private industry, retail, trade, construction, manufacturing. But eradicating workplace violence in healthcare has been elusive. There was a review in 2016 from the New England Journal of Medicine that specifically said, healthcare workplace violence is an underreported, ubiquitous, and persistent problem that has been tolerated and largely ignored. Now, we know that 75% of the 24,000 workplace assaults occurring annually between 2011 and 2013 were in healthcare settings. 3/4 of the 24,000 workplace assaults were in healthcare settings. And healthcare workers are about 20% more likely to become victims of violence than people in any other industry. So I'm going to talk a little bit about, here's more data to sort of illustrate this. And you can see, so all private industry, intentional injury by other person per 10,000 workers, a number as small as 1.7. And then look at where the numbers are the biggest. The big numbers are psychiatric and substance use hospitals, 109.5. Residential mental health facilities, 34.9, other residential facilities, vocational rehabilitation services, which surprised me, 20.8. So in general, we know that this is playing out as generalized data. And we know that the costs are manifold, okay? Verbal aggression is the most insidious and yet the most ignored in clinical settings and research. It's really hard to follow verbal aggression in clinical research for a number of reasons, part because it's so prevalent and it's hard to count. But being called names on a daily basis in an already stressed workplace is wearing at best and can cause severe long-term damage in the forms of things like post-traumatic stress disorder, increased staff turnover, what we call burnout. When an employee gets hurt on the job, hospitals pay the price in many ways as well. Workers' compensation for lost wages and medical costs. We have to put in for temporary staffing, backfilling and overtime when injured employees miss work. When injured employees quit, there's a huge turnover cost and there's decreased productivity and morale. And you can see that happening in hospitals as employees become physically and emotionally fatigued. In addition, healthcare workplace violence can also affect recruitment and retention because experienced individuals will leave and there's an effect on the people who are attempting to come in. They'll see that there's an issue with what's going on in the workplace. To further look at the scope of the problem, the New Hampshire Hospital Association provided me with these data, and they are necessarily anonymized. And that seems to be a really important key factor in all of this talking about aggression and violence. So these are data submitted by hospitals to the American Hospital Association's Health Research and Educational Trust Hospital Improvement and Innovation Network. There's a comprehensive data system, and it was in 2016. And note the legend on the left-hand side, okay? So the number of events per year is reported as the highest at 9 events. Let's see where we got it. For hospital G, okay? And as few as 0 events for a number of hospitals, NWY, U, O, 0, O, Q, ABJ, all those others in a year. So I thought that was pretty remarkable that, we topped out at 9 and there were a lot of hospitals that said there was 0. So we know these numbers are lower than what's probably actually happening, particularly where verbal aggression is involved. And according to the New England Journal of Medicine article and others, underreporting can be as high as 70%. Underreporting can be due to a whole bunch of reasons, including people's reluctance to seem incompetent, like I got hit, but I was probably not doing the right thing, fear of retribution, which is a little bit frightening, and buying into the culture, specifically in healthcare, of the fact that getting hit may be part of the job. And I've seen that at our own state hospital. Other reasons that people talk about are, lack of time to report because staff are just running their legs off, trying to just put out fires. Uncertainty about what to do in order to report, so the facilities aren't making it really clear what the process is. Uncertainty about the definition of violence, and I think we see that in places like nursing homes and places where there's mental health issues. I know people will say to me, well, yeah, I know she broke my jaw, but she had dementia. And I think to myself, a broken jaw is a broken jaw, and it's not a value judgment. This, we need to have these data. It's important because we need to figure out how best to address this. Also, people talk about difficulty filling out forms as well. So you remember the data we showed, right? The topping out at 9 events per year. Well, we asked the same 26 hospitals to monitor themselves for another period. And here's the workplace safety events in New Hampshire by hospital after monitoring. So the before monitoring is a little tiny blue. This is like Howard Johnson. Sorry about for those of you who are old enough to remember Howard Johnson's. Sorry about the coloring, but And then so after the monitoring, and I want to point your attention specifically to the left-hand side, which now the legend is topping out around 80 or 90, which is 10 times what was reported before in the same time span. And yet there are still hospitals that report 0. Now, New Hampshire's a small state, and in particular, Littleton Hospital up north, and I have no idea what any of these are, but Littleton Hospital up north, I know I'm very familiar with because my mother-in-law goes there a lot. There's like 5 beds in the emergency room. I imagine even they have at least one event a year. So, I mean, I just find it really painful to see that somehow people are just so afraid or so unable to collect these data so that we can look at what's working and what's not working and really try to address it in a systematic way. So as I mentioned, so these numbers are really the tip of the iceberg because of underreporting. They're also the tip of the iceberg because research on violence is limited. There are no consistently agreed upon definitions of violence, as I've mentioned before. So we aren't always talking about the same thing. Some people exclude verbal violence from their policies. Some people only include if a hand connects with another part of somebody's body. Second, while I looked at many measures in the literature, only 1 or 2 appear in more than one publication. So mostly, for the most part, there are no commonly agreed upon measures that we can use to compare results between studies or even just between data collection done by different organizations. And finally, and I think this is really important, most of the studies that have been done have not included essential stakeholders, particularly patients, in designing and executing the research. And so by eliminating important stakeholders, we're really not getting the correct data on this, from the research projects. So the Joint Commission recommended that healthcare organizations clearly define workplace violence and put systems into place across their organizations that enable staff to report workplace violence instances, including verbal abuse, as well as to capture, track, and trend all reports of workplace violence, including and attempted assaults when no harm has occurred. So even when no harm, these are the near misses that they're asking people to do. It's easier said than done. What do we really know about what to implement in order to follow through on this Joint Commission requirement? So that leads us really to the research practice gap, the second part. This is a relatively recently published systematic review commissioned by the Agency for Healthcare Research and Quality, done by Bradley Gaines at the University of North Carolina. And I'm focusing only on this first question because there were no studies that met criteria for inclusion on the other 2 key questions. So the authors found 17 studies on comparative benefits of strategies to prevent and de-escalate aggression and to reduce seclusion and restraint. 17 studies, and they looked back considerable amount of time. These are 17 studies that were rigorous enough. They wanted to find the comparative harms of these strategies to see if there were anything, was anything that harmed either patients or staff in the execution of the strategies. They also they wanted to look at characteristics of patients, for example, ethnicity, age, that sort of thing, or intervention components or of acute care settings that modified the strategies, but they also did not find any of those. So of the 17 studies that compared these strategies, most of them were found to have a very high risk of bias. 8 of the studies were randomized controlled trials, 5 were cluster randomized trials, and about half the studies were in the US. The results, here's the results. So they looked at interventions that prevent aggression, de-escalate aggression, and reduce seclusion and restraint. And to make it sort of go straight to the final answer here, I put the X's where there was an insufficient strength of evidence or a high bias in the studies. The lowest bias was in one study that talked about risk assessment to prevent aggression and risk assessment to reduce seclusion and restraint. It's one study, but it was the only one that stood out to everybody. as far as that was concerned. They looked at staff training, all of the different kinds. I was just recently reviewing the paper again, and I think the trainings involved nonviolent crisis intervention, physical interventions. Risk assessment included all sorts of risk assessments, including the BROSET, the MAVIS. There are a whole bunch of other kinds of risk assessment strategies. Multimodal intervention, which I thought was kind of interesting, that includes things like equine therapy, cognitive behavioral therapy, just a whole bunch of other things. Group treatments, having people, in groups and talking about aggression and how to reduce it. And then surprisingly, medications, which I think is something that a lot of, at least psychiatric hospitals, rely on. Do you have the PRNs for, in case something happens overnight? But there's not a heck of a lot of strong evidence supporting that actually prevents aggression, de-escalates it, or reduces seclusion and restraint. This surprised the heck out of me. It really kind of prompted me to keep on, looking more for what could be done. And here's where I could use your expert consultation as well, because you guys are working in this field. We don't yet have accurate and reliable data to measure the results of any interventions we implement, or to help us target the interventions we develop. We have approximate data. Equally, there are few, if any, known evidence-based practices for us to implement at this time. But aggression and violence remain a problem, and it would be foolhardy to simply wait until there was a sufficient evidence base to tap into. And as I mentioned before, this is the opposite of the classic research practice gap that's been described in the literature. So the classic research practice gap, remember, there's solid evidence for preventing or addressing something, and there's a huge lag in implementation. In the workplace violence research practice gap, there's a limited evidence base for what works. There's limited data, and it's not comparable. And yet aggression and violence are still a problem. So I think the way to look at this is that, we're all implementing many things independently, each of us in our own hospitals, outpatient clinics, communities, doing our own interventions and noting sometimes positive and sometimes negative results. But as we've seen, comparative studies are few and far between, so we have little guidance as to what constitutes a solid evidence base. So we know that violence in healthcare is a major public health problem, and we know we have very little data regarding the real prevalence or occurrence, so we don't have much to support particular approaches to assess, mitigate, face, and support acts of violence. And when faced with limited data and limited evidence bases, it's best to probably try to obtain data in order to have a solid base from which to start, which is what prompted us to implement this pilot survey. So there's kind of a backstory here. In 2016, the New Hampshire Senate voted not to support a bill requiring that healthcare facilities perform annual workplace violence risk assessments with written plans for reducing risk. I'm going to repeat that. The Senate voted not to support a bill requiring healthcare facilities to perform annual workplace violence risk assessments with written plans for reducing risk. At the same time, one of the senators here, Senator Gray, was contacted by a constituent who was the victim of a severe assault, and she insisted that Senator Gray follow through on this. So he asked for information about the state of healthcare workplace violence in New Hampshire. The then CEO of New Hampshire Hospital, the hospital I work in, convened a group of interested parties from around the state to discuss how best to approach this request. And these are some of the folks who were involved. There are a bunch of professors from the University of New Hampshire, who my colleagues, and I really appreciate their input. And then there was a group of student nurses who actually crafted and tested the initial pilot survey. So our first goal was to survey a cross-section of one of the larger counties to establish the incidence and prevalence of workplace violence, from anything from licensed and unlicensed home healthcare providers to outpatient and ambulatory facilities to inpatient and nursing homes. We wanted to get the whole spectrum within one county. And I think it was a great idea, but we sent an anonymous REDCap-based survey and ended up using snowball sampling, because every time we contacted folks, we were told that either the institution's IRB did not approve of us doing this sort of thing. Even when we talked about anonymized data, people did not give us reliable contact lists. Information wasn't passed on. Hospitals and outpatient facilities were extremely reluctant to part with any of these data. And this is what I call the dirty little secret of, I don't think it's New Hampshire's dirty little secret. I think it's probably a dirty little secret all over. But it was really dismaying to see. So here are some of the survey details and demographics, recognizing that it was, the sample we could get. We conducted it between January 15th and March 30th in 2020, so relatively recently, and before really that which shall not be named, COVID-19 seemed to hit big. We had 244 participants. And because a lot of the lists that we did have were nursing and licensed nursing assistants lists, we had 89% of the group was female. 65% had more than 10 years experience. About half were between the ages of 46 and 65, extremely young in my opinion, but 2/3 were nurses and 1/4 were licensed nursing assistants or medical assistants. And then of the places they worked and the amount of time, most people were full-time. About 1/3 were working inpatient in a 5th ambulatory, a 5th nursing home, 15%, 16% emergency department, and then there's about 9 to 10% assisted living or home care. So we got a broad variety of responses. And the specific results showed that 73% of all of these folks experienced some form of violence within the previous 6 months. More of the men than women reported experience some form of violence, even though the number of men was smaller. 82% of those working fewer than 5 years experienced violence versus 67% of those working more than 10 years. So, there may be an experience factor involved here. More people on evenings reported than nights or days. 88% of those working more than 12 hours reported, and that makes sense if you're working longer hours. And 16 out of 21 experienced verbal, physical, harassment, intimidation, and sexual aggression. Half of them reported it during specifically patient care. So we also asked about the sources of violence. And as I mentioned before, this type 2 violence, patients to staff, seems to be the greatest. And here it comprised 81% of our group. 23% were violence from a relative of patient to staff. 13% was a visitor. And surprisingly, the another employee was a write-in. We didn't ask specifically about horizontal violence in this survey, but people wrote in, 15% of folks wrote in and said, there was somebody, another, either another, usually it was a nurse, but a colleague perpetrated this violence. So the types of aggression experienced, as you can see, verbal, far and away the most common. Physical is the second most common, with harassment, next intimidation, and then sexual violence, the least frequently encountered, although it's most frequently encountered in nursing homes, interestingly enough. When we broke it down, looked at the location of violence, 93% of the violence was occurring in emergency departments. 85% was in inpatient facilities, 76% was in nursing homes, and about a little bit of more than half was in ambulatory care. So, it spans the range, with emergency departments being the most likely. And then the location of violence itself was mostly in patients' rooms, all the way down to things like patients' homes and medication rooms. But I thought it was kind of interesting that, especially for inpatient and for inpatient facilities, you got to go in there. And so that's where it's most likely to happen. When we asked about the types of injuries people had, it was really, really interesting. I mean, people talked about, back injuries, pulled muscles, scratches, sprains, testicular trauma, bites. 2 people out of 244 mentioned mental health sequelae, which I thought was really remarkable. I would have thought that more people would have said something about that. Now, of course, we had a limited sample, but I just thought that was remarkable to think about. We were also kind of curious about who reports, okay? So, for example, of the folks in emergency departments who experienced violence, 21% reported it. Of the folks in nursing homes, 32% reported it. Of the inpatient, 24% reported it. And in ambulatory, 23% reported it. So pretty low reporting percentages. And the reason that people did not report was, as we mentioned before, right? There were folks who felt like it was not intentional. This was a psychotic person. This was someone with dementia. There were folks who weren't certain if they were supposed to. 4% said they were afraid of repercussions. Some folks were unaware that a system for reporting even existed. So that's all the data about who and what. What we were also interested in was what helps providers feel protected in their environments. Because we know that most people, that 62%, when we ask them flat out, do you feel protected or do you feel safe in your workplace? 62% said absolutely not. So what seemed to help a lot for most folks is having a security team on site. But also what was interesting was having a supervisor that supported reporting regardless, whether or not it's sort of like a non-judgmental supervisor. You need to report this. It doesn't matter what, what it was, what caused it. And then from there, it's other things that people talk about. But, surprisingly, training is not a big part of it. Knowledge is not a big part of it. Having security teams and supervisor supports really was, seemed to be the theme here. So that's our pilot survey. And as I mentioned, it's a really small survey. It was a convenient sampling. So there are limitations, right? It was non-random sampling. Let me take a sip of grapefruit. And the sample size was limited. However, when we did the analysis, the data analysis, we could make certain conclusions based on the information that we had. We could make the conclusion that violent events occurred across all age groups, across all healthcare settings, and multiple times per week. There was no doubt about that. And the violent events originated from multiple sources, including patients, family members, and workers. So at that point, we sat down and said, so what do we do next, right? Given we have a serious public health problem and we've limited data and evidence for what to do, this is kind of the dialectic that we face, and I'm curious how many of you in the audience are facing similar challenges. What do you do next? You think about, is the evidence currently available sufficient for making implementation decisions? Should we delay until more evidence becomes available? And really, how much do, implementing quality measures, how much does that matter when the evidence base for the measures is really not tremendously clear? So based on the pilot survey results, our New Hampshire Workplace Violence Group recommended a number of actions. And primary recommendations for next steps generally center around supporting action at the organizational level, to ensure implementation of agency level policies, training, other service to improve staff and patient safety, additional research on the prevalence drivers and protective factors, multi-organizational quality improvement efforts to build upon lessons learned, statewide policy changes to ensure that healthcare providers have adequate resources and supportive environmental and cultural redesign to decrease the risk and provide a safe, supportive environment for healthcare providers and patients. And our group is moving forward on the green item 3, by combining the benefits of organizational action and ongoing research a consortium of healthcare organizations can work together to learn about the most effective steps which could be taken to improve staff and patient safety. And in doing that, we really would not only add to the body of research on what works, but we're also able to fine tune the application of best practices, given the unique dynamics of each organization, because each organization is not a one size fits all. And we can show systematic improvement in an area that can have far reaching implications on the ability of each organization to achieve its healthcare mission. Any questions so far? Okay. So I think one place we could start is to view what we're doing in this field as a sort of a marriage between quality improvement and research, in that we are likely using what we know as best practices currently. They're certainly not evidence-based practices. And in using and refining these practices, we're generating new knowledge at a microsystem level, right at the level of your emergency department or your hospital. And somehow we have to figure out how to pool all of our microsystem information into a larger system so it could be evaluated for whether it works on a larger scale. And I don't know the answer to how to do this, but I think some of you may have some ideas and I'd be interested in hearing about them when we come to the question part. So one thought I had was this, could you imagine setting up a collaborative that includes representation from all stakeholders, okay? The collaborative would have people from quality improvement, evidence-based medicine experts, people who would help figure out together what definitions to use going forward and what measures would best represent the data that we would want to collect and analyze. And we could share our data that comes from each of our hospitals, engaging in individual experimental labs, do our own little plan, do, study, act cycles, and contribute to the general knowledge about what works and what doesn't in our respective systems. And there's precedent to support this, actually. There's something called the Northern New England Cardiovascular Disease Study Group that it was started many, many years ago when hospitals did not want to publish their mortality data for certain cardiovascular procedures like intra-aortic balloons and things like that. And a consortium was started. De-identified, anonymized data was disseminated, but people knew where, what their own data were in comparison to the other hospitals. And it helped people kind of open up in this consortium. People felt like it was a safe place to start talking about, well, what is it that you do? How many times do you sterilize that? And I'm making this up because, it's been a long time since I've done regular internal medicine. How often do you sterilize these things? Or, how do you interpret these numbers? And people started visiting each other's facilities and seeing what worked for some folks and what wasn't working for other folks. There's also the Success with Therapy Cystic Fibrosis Research Consortium, which has a similar basis, a similar idea. So overall, the idea is adopting the same language, involving all stakeholders, finding, developing, whatever it is that you need to do to get the data you want, common measures that you can use to compare data. Create and test interventions that you're using, or look at the interventions you're already using, and then form consortia and share this de-identified aggression and violence data. So what role can all of this play in managing aggression and violence in psychiatry? I think we really have an opportunity to reduce aggression and violence on certainly psychiatric inpatient units and probably other healthcare workplace facilities by collaborating across professions, including all stakeholders, agreeing on and adopting common definitions of terms, and developing useful, informative, and psychometrically sound data collection instruments that fit into the daily workflow. I discovered that when we tried to put collection instruments into place at New Hampshire Hospital. And by comparing each of our own systems' data before and after interventions to determine the cause of variation in practices and outcomes. I think we have a lot of collective wisdom to share and so much to gain from sharing it. Thank you. And I'm going to ask if there are any questions.
Thank you so much. And folks can put questions in the chat or indicate that you'd like to unmute and we can ask questions there too. I have a couple that have come to me that folks have been sending that I could throw out. But first, Dr. Missler, I was wondering if you could just speak about the security came up as something that was really important for the folks that you had surveyed. And I remember you describing kind of to me, what seemed like a unique relationship between security on your campuses and the patients. I was wondering if you could just talk about that a little bit.
Right. So there are some, the security at New Hampshire Hospital, the state's only state psychiatric hospital, is actually offered by the state police, and they are on campus. They are in-house. It's sort of a special branch of the state police. And initially, the state police felt kind of put off when they were first housed here. And the staff was a little bit put off as well, because here are these people with these, uniforms that usually they cause all sphincters to tighten when you're driving. So they had a difficult relationship, and one of the heads of nursing decided to address this by talking to the chief of police, and they started talking about languages, and they recognized that they have common interests. Everybody wants to make sure that everybody's safe in the hospital, that people don't get hurt, but that there were languages, the language just wasn't a common thing. And so they started talking about sharing that language and describing to each other what some of these differences were. And in doing so, they actually found out things that the other person does to help de-escalate or reduce violence. And so what has happened in this hospital is that the police actually have a regular presence on the units. They have rounds that they swing by and say hi to folks and, socialize with patients, so that patients don't come to associate them only with when there are codes, when there are disasters happening. I think, the police officers get more comfortable, and ultimately it's been much more helpful for the nursing staff as well, because I think they feel better when there's a systematized way that the nurses call in the police. And if a situation gets out of the control of the nursing staff, they actually officially hand over the situation to the state police. And they'll say, I can no longer handle this, now it's yours. And that's when the state police use their outside voices, as they call it. Doesn't happen a lot, but it can be very effective when, it's necessary. I mean, if somebody is breaking, huge pieces of equipment and they're threatening, it's usually when there's a weapon involved. I know across the state, we tried to do some training of other facilities, other hospitals, and connect them with their local police community. And I think people were kind of surprised when they did this. They sat down, the police sat down, the nursing staff sat down and started talking about these differences in language. And I think both sides learned a fair bit. I mean, I think one of the things the nurses talked about was, they had specific patients. And once again, New Hampshire's a small state. So, but, they had specific patients that they had, some difficulties with, and they didn't understand why the police had such a great relationship with them. And for example, an example that really sticks out in my mind is one policeman said, every time I come into that emergency room, Joe is sitting there and, he's asking for something to drink and nobody gets him anything. And so I usually come by, bring him a Coke and I bring him a sandwich and we play checkers. Now I understand that people have time limitations, but I mean, once again, being able to accommodate someone, even just a drink and a snack, that kind of stuff, it just seemed to make a huge difference. Is that kind of what you were asking about?
That's exactly it. I remember being struck by hearing about the relationship that we have across our system, lots of different hospitals, and security has different relationships with both patients and staff, and different levels of presence with patients and staff at each hospital. At some of our settings, we've had nursing and other disciplines say we would like more. At others, it might be different. And so it's I remember and appreciate hearing the kind of friendly face that security can provide on a unit when it's done that way, and how that can be reassuring both for patients and for staff.
Absolutely. I mean, because the more I read the literature, the more I see also that patients are afraid to be on units where violence is happening as well. So yeah.
One clarification that was sent to me, when you're in your hospital settings, when police are making rounds, are there visible weapons, and are they present during restraints?
So the only weapons that the police have here are tasers, and that was kind of a big, I know that's a big controversy even internationally about whether or not police in certain mental health care facilities have weapons. The tasers are visible. The police don't deploy them except in extremely, serious situations. But I think people know that there's just no firearms, no other weapons, no batons, nothing like that. And I think the tasers may have been deployed 2 to 3 times per year at most. I've seen the taser data for, given how many codes code grays, we've had like 900, 800 per year, something like that. So out of all of that, it's not a lot of times to deploy something. We do have a lot of injuries, so.
Dr. Newfield, please.
Hey there, thanks so much for your talk. Going along with public safety and police presence, at our Westport campus down here in the Fairfield region, we do have security staff on site, sort of public safety officers who carry pepper spray. And I think that's been a nice, relatively safe intermediate for when things get really escalated out of hand. They always have to write, sort of a documentation on why they deployed it when they did.
Oh, yeah.
And I'd say that they've been relatively well balanced at only using it. I think it's been an average of about once a year for around 92 inpatient beds and around six emergency department beds. And so that's been a well-utilized, well-deployed, obviously it's regretful when it gets to that point,
Absolutely.
but I think it's done a lot more to keep people safe. And as for how to engage public safety staff, making sure that at Westport, when we make decisions about patient care issues that in some ways might have a security or safety or violence component to them, that we include them in the discussion. If we're having court hearings that we feel might cause patients agitation, that they're very included in the discussion and maybe doing higher frequency rounds on units where that sort of thing is happening. But further out, when it comes to police, our local police, we found, you talked about the language differences and concerns, and I think just having an open dialogue is really, really important. And so we found it, of good value to bring, the chief or some of his designees, some of the lieutenants down, for a meet and greet lunch where our administration could sit down with them once or twice a year. It's been a lot less since COVID, but it's really helped the relationship and, helped the respect and sort of gotten a mutual lingo and sort of been able to identify pressure points which each are feeling that you can then sort of relay and discuss and work on, in problems going forward. So it's been really helpful. And, I just thought I'd piggyback on what you said and share some of our experiences.
Yeah, no, I think that's wonderful. That reminds me of some of the things that some of the police officers and the staff would talk about in the state trainings we talked about. One of which was sometimes the police officers would say, why don't you just give them a medicine? And sometimes the nurses would say, why don't you just arrest him? And so having that understanding of what the limitations of the statutes are, or the revised statute, the healthcare limitations, really, really does help. I think, knowing more about the other person's job can make a huge difference. So I really appreciate that. I'm curious about the difference between the pepper spray and the tasers. I'm gonna have to go look that up, because I have no idea why New Hampshire decided on tasers. I didn't follow any of it, but.
Dr. Missler, I have a question from our VP of Quality and Safety. who gets right to the point. She said, "What should we do? What interventions should we be using? What works?" And obviously that's in the context of your presentation. But what are the big ticket items that you recommend?
Well, I mean, from the research, it looks like, it's hard to actually say, right? I mean, if we know that out of these 17 studies, there was one that had a low risk of bias that had something to do with risk assessment, reducing potential aggression and violence. I guess, risk assessment is one of the thoughts. Nobody has specified a particular risk assessment, and I've got to tell you, the best risk assessment, which I believe is, like the BROSET and some of those others, really only predicts out to 24 hours. There's nothing that's going to predict within the next 2 or 3 hours even, honestly. And yeah, I mean, I get excited about things like, wearable digital stuff that can detect people's heart rates and stuff like that, that can predict within 2 minutes, which I think would be remarkable. So having more information and sharing our information is what's going to be most helpful. Implementing what seems to have worked, and then just studying it and making sure you don't institutionalize something, right? So this is the way the hospital's always done it. I'm sure nobody's ever heard that, right? I've heard it since 20 years I've been in this hospital, but making sure you're open to making changes, and always including the stakeholders, as you've mentioned. I mean, patients have to be involved, employees, staff have to be involved, and from all of the different parts of, if it's a hospital or if it's another facility, home health care, because the people who work the front lines know, right? They know. They can often tell when something bad's going to happen, that sort of stuff, and they can give you some information on what might be more useful. And that's kind of how our Chief Nursing Officer, Diane Allen, did it when she implemented something called Staying Safe, where she got everybody together. She had, she polled the staff. She found out that people felt like, if there were 5 people, that minimized the risk in doing a restraint. So she had this thing about, don't jump into trying to protect other people right away. Don't feel like it's urgent. Just keep safe until 5 people come. Because that's where a lot of our injuries were happening, was, 1 or 2 people were getting into, the fray, feeling like it was their job. We have to protect the, embarrassingly, the docs, the nurses, that sort of stuff. And it's weird how that all got to be a cultural thing, but breaking that down into, look, you need to protect yourself, and you need to all be protecting other patients. So I don't have specific statements. I mean, I wish I did. We've been trying to implement, it may sound a little nihilistic actually, we've been trying to implement a common measure in this hospital. I've been working on it for like 6 or 7 years, the modified overt aggression scale. It's actually in our electronic record, but we are so low staffed at this point that the nurses don't have time to fill it out. And it's 4 things, 4 items, right, at the end of each shift for each patient. I've done trainings on it, all that sort of stuff. And it's just, people are putting out fires. They find it really difficult to do anything more than that. And I don't know a good answer to that, frankly.
Dr. Newfield, are you jumping on again? Okay. I had a question. We had a question about acuity, and one of the things that comes up when we look at violent events is often one of the factors, maybe not the root cause, but a significant cause contributing to events seems to be high acuity units. And I was wondering if you have any thoughts about how we can mitigate that aspect of risk proactively, or just think about it.
Acuity is fascinating. I'm really glad you brought that up, actually, because we did some studies here. There are, I think I've seen 1 psychiatric unit acuity measure in the literature. And we had some folks here from one of the local schools try to pilot an acuity measure which ended up being mostly the elements of the modified overt aggression scale, just saying. Because it's different from, I mean, there's tons of medical acuity measures, you know, the how much somebody requires, you know, medication changes and, you know, changing the bed clothes and, you know, blood draws and stuff like that. There's a lot of those sort of actions that don't come into behavioral health care. It's sort of a different issue entirely. And the other thing that's key is time. And as I've been talking to folks like in the elderly care folks, you know, in nursing homes, that seems to be one of the big issues, is that they feel like if they had more time to engage and spend with patients, they'd be less likely to get hit by folks who are, you know, confused, afraid, having difficulties with memory, dementia, but they don't. They're, you know, they're supposed to be doing all these tasks. It's very task oriented and not very person oriented. That's not a direct answer, but I think, you know, the acuity may actually be, well, I don't know if the snake biting its tail is the thing, but just the idea that acuity may be a function of how we are now defining what is healthcare, you know, this task-based thing, as opposed to having more time with folks. Whether that means having more people or having different levels of expertise of those people, because it doesn't necessarily mean if you have more nurses on a unit, that doesn't necessarily mean you have less violence. It's the mixture of the folks that you have on the unit.
Thank you, and folks can keep sending me questions if you have them. One thing you mentioned earlier, you had mentioned that, you know, although folks were comfortable reporting physical assaults, or the sequelae of physical violence, they didn't report mental health symptoms. And a lot of this work has been done in psychiatric facilities. I was wondering if you could comment on, you know, the impact of stigma, and, you know, if you think that relates to workers' comp or, you know, deleterious outcomes for our staff, the inability to kind of acknowledge when there is an emotional event or assault that occurs.
Yeah, it's shocking, actually. I think, you know, I think people feel deeply ashamed when something like this happens to them. That there's, you know, as I said, people sometimes feel like I did something wrong. They don't, and especially if they don't have the support of the folks in their administration for this, it does sort of reinforce the stigma associated with it. And people also, that's why people, I think, do the idea of, you know, it didn't matter because it was somebody with dementia, or it didn't matter because it was somebody who was psychotic. You know, that kind of reinforces the stigma too, in an interesting sort of way. I mean, to me, it's very black and white. You know, there was an aggressive incident. We need to figure out how to address it. It doesn't mean that the person was bad or good. And I'm still surprised at how much this persists. I mean, you look in the literature, this has been in the literature since the, you know, 70s, probably even earlier than that. And yet it's still this huge problem.
Knowing that the answer is probably all the above, how would you address that? Is it, you know, peer-to-peer? Is it local leadership? Is it administrative support? You know, one thing that we've spoken about in our initiative is, and this is a very extremely small thing that we've spoken about in our initiative, but very important, is when someone is the victim or has had an event happen, you know, who should follow up, and is there meaning and value in having not, you know, our director of nursing at IOL will, I think, follows up really rapidly and probably really frequently after someone there's a physical assault. Is there value in having other levels of leadership be involved? Is there, you know, what should we be offering proactively? EAP, psychological first aid? Are there other things that we should be thinking about after events happen?
Yeah.
And of course, normalizing the response, you know, the natural responses.
I agree. The other thing is, this is why I talk about data so much, because a lot of times the data that's happening, you know, from a particular institution is not shared with everybody. So people think they're the only ones that this is happening to. And I think, you know, people want to tell the story, especially people who have been traumatized. and having people that really understand that they've gone through something that is deeply traumatizing, and at a place where they're going to have to come back if they choose to. I mean, how many other people that do work other than, say, police officers, folks like that, have to do something like that and face that down every day? I honestly don't know how some of the staff here at this hospital do it. There's people who've had concussions and who've had their eyes gouged, and I mean, I don't know, but I think it's helped to have people, accompany them to the ED and talk to them about what happened, and making sure that there's follow-up and that people acknowledge that it happened. It's not something they covered up.
Makes a lot of sense, and better than my all of the above answer. Thank you.
Oh no.
Thank you for that. I had a question sent to me. Is anyone looking at the impact of assaults on psych units on the patients, on other patients?
Yes. That's a wonderful question. Yes, people are starting to look at that. It's one of those things that seems that comes under sort of the environment and modifications to the environment, and it sure does, as you might imagine, affect other patients' ability to recover and their mental health. I've had patients tell me when I go on rounds, like, I just saw somebody get thrown in the box. That's what they call a seclusion room. And it's like, I'm afraid, A, they're going to throw me in the box, or B, that person's going to hurt me. And I think about it. A lot of our rooms are double rooms, right? And how would it feel to go to sleep at night knowing that the person, you don't know what they're going to do, the other person in that other bed? I mean, it's hard enough being married, but no, but I mean, seriously, it's, that's frightening. And this is where putting vulnerable people in situations like that, and how can we address that? I noticed that my unit is a single bed units, single bed rooms, and people far prefer it. They feel much safer. And we've got a lot of, as you do too, probably traumatized folks. So that makes a difference. That makes a difference. I mean, the unit that I have is actually probably one of the higher rated units in the hospital. I mean, people actually ask to come to it. We have nurses that are trauma focused trained. We spend a lot more time. We don't have a restraint bed. We spend a lot more time with folks. We have a much lower seclusion rate than any of the other units. But it's time that we spend with people, sitting there and spending time.
And you just said you don't have a restraint bed?
Not on my unit, no.
I imagine at some point that was a culture change.
Yeah, we were yeah, exactly. We're testing it out. I think there were people in this hospital when it was proposed years ago. It's like, you're kidding me, right? How's that going to happen? But knock on wood, we've had some really good experiences with spending time with patients, sitting with patients, understanding patients. Old-fashioned.
And thank you so much for these answers. I have another question. Are you aware, and this kind of, tying into something you mentioned earlier, the police officer who notices that the person needs a drink. Mm-hmm. Have folks been looking at the level of upset or the patient experience of unmet need and how that relates to violence?
Yeah, actually, so the folks in England, there's a bunch of folks, Joy Duxbury, Lynn Bowers, who's retired now, but there's a number of people who have done a lot of work in aggression and violence. The folks who developed safe wards, for instance, and they recommend making sure you pay attention, sort of like a little mental checklist, right? And I'm not saying that patients are children, but in your mind, when you've got somebody that's a child that's crying, it's like you go through your list, right? Are they tired? Are they hungry? Are they wet? You want to ask that specifically because sometimes people's cognition is impaired, as you know, or their ability to communicate what's going on is impaired. So yeah, that's definitely something that's so important. I discovered on a neuropsych unit that we had once that unrecognized pain was probably the most likely to cause someone to become violent.
That's helpful. Do you have other risk factors that you think about, or significant risk factors? I mean, pain is something that is on our list of things that we're thinking about as well. Broset scores are things that we're thinking about. Other sorts of things that we should think about?
So I am my mother's child, and I'll say staff pissing people off. If you don't mind that language, that sometimes people on staff don't see how their interaction with somebody is actually making things worse. And taking a deep breath, hoping that, I don't get hate mail, and it's not the only reason, but you see it all the time of folks, getting into a conversation, maybe not trained to have an interview with somebody that is a considered interview that you're taking in a particular direction. Do you know what I mean? It's just sort of, I've just seen it happen so many times, and people aren't reading the room. They're not reading what the person's feedback is, the person's physical responses, and just pushing it harder and harder, and then it starts to explode. Does that make some sense? No?
It does.
There's probably a gentler way of saying that, but like I said, my mother's from Queens, New York, so just like
thinking about how we interact with one another, and is important. One, this isn't a question. I have a note that there's interest in us joining your consortium if you'll take folks from Connecticut also.
That's very interesting. I'll be happy to bring it to the work group and see what their thoughts are, but I think they would be very excited.
We won't put you on the spot and hold you for an answer right now. Well, I thank you for your time. It was a really enjoyable conversation. And if anyone has any other questions, it's your last chance to shoot them at us. We have a whole bunch of things that we're doing here and in the system that I'd love to run by you, but it doesn't have to be publicly. And see what you think about them, and if you can help give us some guidance. We really appreciate your expertise.
Oh, I look forward to talking. And if people want, did I give my email address? I might not have actually.
I don't think so.
Yeah, so it's my name down here, lisa.a.missler, and just add on at dartmouth.edu. That's Dartmouth, DARTMOUTH.edu. And I'm happy to answer.
And folks can contact me as well, and I can connect them if they miss that.
Perfect.
Again, thank you so much for your time.
Oh, thank you guys. I appreciate your attention. I know your time is important, and I appreciate you.
Hey, Kevin. Thank you, Dr. Missler, again. Kevin, you had said that you might put the CME information up again. Can we put that slide up one more time? Thanks so much.
Sure. It's 25619 is the code.
Yeah, and
the phone number.
Yeah.
You want me to bring up the?
Sure.
Yeah, I'll bring up the slide. How's that? And show, and then
you're gonna have to share a screen again. We already were successful once. It's going to be.
Got it. Let's see. Share. That helpful?
Yes, very much. Thank you.
You're welcome. I'm proud of myself.
Doctor?
Yes.
Real quick, I just want to say, from Queens or not, I appreciate your directness. It is much needed because what you spoke was truthful, and we all need to be mindful, including myself, of the room and our approach and being able to adapt and adjust in any situation. So keep being a straight shooter, and it wasn't rough at all. It was needed, and I appreciate you for that. Thank you so much.
Thank you for the feedback. Yeah, no, there are times
you're welcome.
I'm sort of like, I've just put my foot in my mouth. It's like if I'm too tired, if there's something going on, and I just get, yeah, exactly. I forget. And
no, it's needed. You didn't come across in any way. And I think if someone is to take that comment and feel some kind of way, then they might be one of the people that needs to perhaps change their approach, because I appreciated it. So thank you.
You're welcome.
Have a great day. Thank you, everyone.
Yes.
Thanks again.
All right. see if I can figure out how to say goodbye.